All right. Why don't we go ahead and get started? It's about 1:01. So for purpose of time, we'll get things kicked off here. So welcome everybody. Welcome to the client webinar here for quarter one, Hudson 340B. Good afternoon to everybody, and good morning to some of you out there. We're happy to be hosting this webinar and welcome. So before we begin and jump into the actual content, I just wanted to let folks know kind of the agenda we have here today will be we have Mark Ogunsusi from Powers Law Firm. I'll introduce Mark in a moment. And we also have Nate Arich here at Hudson 340B, and Nate will introduce himself here shortly after Mark's presentation. So this is our first webinar of 2024. Towards the end of Q1, it's really hard to believe that it's quarter one is almost behind us already and heading it into quarter two. So our goal here is to have quarterly webinars. We think that's a good cadence, timely every quarter. There's a lot of different webinars out there that folks participate in and can attend, and we don't want to certainly overdo it. And we have pretty regular check-ins with our clients anyways, as you all know. And we certainly want to get to you the most up-to-date information here. So we'll kick off with Mark in a moment, then we'll follow with Nate. And so two separate topics today. And we'll probably go between 40 and 45 minutes between Mark and Nate. We want to make sure that we leave plenty of time at the end for Q&A. So Rachel Sari's on the webinar here, and she's monitoring the Q&A, and we'll jump into the Q&A at the end. But on the right hand, at the top of your screen, you'll see the Q&A. So if you do have questions throughout the presentation, please just pop them into that. Rachel's gathering those questions, and we'll go through each of those questions for Mark and Nate. So, realizing where we are with 340B, we realize here at Hudson 340B, it's ever changing and fast paced, hence the title of our webinar, The Changing Landscape of 340B. Legislatively on the federal level, on the state level, which Mark will get into all of the details on that. And then here at Hudson 340B too, ever changing landscape here with some new offerings that Nate will get into the second half of the webinar, but we certainly want to leave plenty of time for Q&A at the end. So we'll have probably 10 or 15 minutes at the end, and the goal will be to get done a few minutes prior to 2 o'clock, if not sooner. So certainly challenging times and turbulent times. I think we all feel that in 340B in this ecosystem, and to be frank, sometimes can be very confusing. So how do we address that? We acknowledge that here at Hudson 340B, and one of the ways we do that is just staying close to all of our clients and making sure we're getting out in front of you. We're having whether it be monthly check-ins or quarterly business reviews, catching up at conferences or webinar like this. We want to make sure that we're arming you with the most up-to-date information and just staying out in front of that. So certainly open to any other vehicles that you all may want to see in the future. We'll include that in our upcoming quarter two client satisfaction survey that we send out quarterly. So that'll be coming mid to late April, and that'll be one of the topics in there, webinar topics and any other vehicles that you folks would want to see from a communication standpoint. So one of our core strategies, providing our clients with the best possible service in the industry. That's something we really pride ourselves on, and I hope each and every one of you know that here. That's what we hang our hat on, as our service, getting out front and taking care of you with a proactive approach. And one of those is communication, and there's been a lot of chatter out there on a state level, on a federal level, of what's happening with 340B legislation. So we think it's relevant. It's a relevant time right now to have take a pause, take a breath, take an hour of your day just to review where things are at on the state level and a federal level. Then we'll get into some other internal things we have going on here, and Nate can discuss those as we move on. So first and foremost, before I hand the floor over to Mark, I'd like to introduce Mark. Mark has become a great partner of ours, working at Powers Law Firm. And Mark, if you don't mind, I'm just going to read your bio here. It's impressive to read through, and we're really happy to have you participating on the webinar with us today. So certainly appreciate your time and joining us today. So Mark Ogunsusi is an associate in the Drug Pricing and 340B Program Practice Group of Powers, Piles, Sutter, and Verville. He focuses practice primarily on regulatory matters involving pharmaceutical pricing, and specifically the 340B Federal Drug Discount Program. In addition to his legal degree, Mark is also a doctor of pharmacy. He regularly advises on an array of healthcare entities on the nuances of the 340B program, the Medicaid drug rebate program, federal pharmacy law, food and drug law, and state pharmacy law. Mark has significant experience in all aspects of the 340B program, including covered entity registrations, contract pharmacy arrangements, patient eligibility determinations, duplicate discount issues, drug inventory management eligibility requirements, third-party vendor arrangements, auditable records requirements, and other 340B program compliance matters. Mark earned his law degree from Georgetown University and graduated with a doctorate of pharmacy degree from Mercer University College of Pharmacy. So with that, Mark, the floor is yours. Thanks for joining us again today. I know you're going to be sharing some of your slides here, and then we'll get through. And like I mentioned before, folks, as Mark shares his slides up on the screen here, we will be taking Q&A. If you want to just pop the questions in the Q&A at the top, we will address those questions as we get towards the end of the hour here. So with that, Mark, I'm going to turn it over to you.
So just confirming, you see the slides?
We
Yes.
do.
Yep.
All right, thanks, Mike. And thanks, Hudson 340B. This is a great opportunity to speak to your clients, and we appreciate everything you're doing to protect the 340B program. The way you introduced the current state of 340B, I think, is spot on. As you all know, I was asked to discuss the state and federal advocacy in legislative matters, some of the adjudicatory cases that are going on with respect to contract pharmacies. As we all know, beginning in 2020, drug makers began to restrict contract pharmacy arrangements, thereby threatening the public health infrastructure of the country. And that's kind of been the impetus of a lot of 340B program revisions or the focus on revising the program. Manufacturers claim that they've been voluntarily delivering drugs to contract pharmacies since before the statute was enacted, but since 1992 at least, which we kind of find hard to believe. And they use the statute's silence on delivery or distribution, it doesn't mention the term pharmacies once, as the basis for their restrictions that have threatened the nation's public health system. So that's kind of the focus of this presentation. It's kind of the focus of program reform. Just a quick statement on conflicts. I have minor stocks in a couple of drug companies. My work probably undermines the stock value in that I try to protect the public health system, which many drug makers don't like with respect to their profits. And please do not rely on the materials in this presentation as legal advice. So we're going to go over state contract pharmacy law adjudication, which is basically the lawsuits, which is timely, as many of you probably already know, regarding the 8th Circuit decision in Arkansas regarding its state contract pharmacy law. Then we're going to talk about state contract pharmacy law advocacy. I think we're at about 21 states that have introduced or enacted bills to protect distribution of 340B drugs to contract pharmacies. So we're going to go over that. And I'm going to give you some really in-depth insight on how to defend those laws and some of the talking points, the key talking points that we've seen pharma use. Then we're going to go into proposed federal solutions, namely Matsui's bill and the Gang of Six discussion draft. And we're not going to get into what could be the forthcoming NAC Pharma ASAP 340B bill because we don't know what that looks like yet. So state and federal adjudicative possibilities. So we'll start with Arkansas. Good old Arkansas. As many of you may know, Arkansas kind of has been a leader with respect to pharmacy reform, state laws with respect to pharmacy, and adjudicating those laws all the way up to the Supreme Court. Beginning with Rutledge with VPCMA, which I believe was around 2019, 2020, reached the Supreme Court. Basically, a ERISA preemption case where the Supreme Court ruled that state laws that set a minimum reimbursement for pharmacies are not preempted under ERISA. That was Landmark, and it was Rutledge, who was the Attorney General for Arkansas. So Arkansas passed Act 1103 following the drug makers' unilateral restrictions on delivery of drugs or distribution of drugs to pharmacies. And Act 1103 was written intended to protect against exactly that. It was to prohibit manufacturers from restricting the acquisition or delivery of drugs to pharmacies. Arkansas covered entities contracted with these pharmacies should be able to retain the ability to acquire and have drugs delivered to their pharmacies. The drugs have to be purchased by the covered entity. And so the drug maker sued, alleging that 2 points. One, that the federal 340B statute is so comprehensive it leaves no room for states to regulate the delivery of drugs to pharmacies. And two, that and therefore Act 1103 should be preempted. And two, that the Act 1103, by saying drug makers must deliver drugs to pharmacies, would regulate purely out-of-state transactions, and that should be deemed unconstitutional under the Dormant Commerce Clause of our Constitution. So, Powers Law Firm was hired by the FQHC Association in Arkansas. It's Community Health Centers of Arkansas, and also Piggott Community Hospital to defend the law. And as you all may know, Bill Von Osen, who helped write the 340B statute, we have a deep knowledge of the contract pharmacy arrangements. At the end of the day, the 340 statute is silent on delivery of drugs to pharmacies. There are two lines of cases, right? It's the state law cases, and then there's the lawsuits between HHS and the drug companies. The HHS lawsuits are basically saying that the government says that the drug makers may not restrict or condition their responsibility to offer 340B prices on the delivery of the drug. So basically they're saying you must offer 340B prices, notwithstanding where the drug is delivered. And that's going to come up again when we get to federal reform with respect to Matsui's bill. Contrastingly, the drug companies say, well, the 340B statute is silent on delivery. It doesn't mention the term pharmacies once. Therefore, we can condition our 340B prices on the delivery location of the drug because we're not obligated to deliver the drug. And so they made that argument with respect to HHS, saying why they can condition their prices on the delivery because they're not obligated to deliver because the statute's silent on delivery. But then when Arkansas passed its law to fill in that gap on the statute silence on delivery, the drug companies made the exact opposite argument, that the 340B statute is so comprehensive, states cannot regulate delivery. So obviously, we cited that. If you go to 340B ESP or any of these websites where all the manufacturers' policies are listed, they're all called limited distribution policies, and they all specify distribution as to what they're limiting. So naturally, we filed our lawsuit basically we intervened to protect the state law on the grounds that if the statute is silent, well, certainly states may continue to regulate, the delivery of drugs to pharmacies. And the reason I went into that background, instead of just giving you a quick explanation of the case, is because this is critical to your understanding of how the state laws to protect contract pharmacy arrangements must be drafted to withstand preemption challenges. So really quickly on the Dormant Commerce Clause, the drug companies dropped that Pharmaceutical Research Manufacturers of America, the trade association for drug makers, dropped the Dormant Commerce Clause argument because we identified a Supreme Court case that basically invalidates that as a valid constitutional argument. States draft laws all the time that have some kind of indirect impact on out-of-state transactions. You can't rely on that to supplant the supreme power of the state to protect public health and safety within its borders. So they dropped it at this time, and we don't expect them to pick it up. They didn't even raise that as an argument in the Louisiana lawsuit. So the case we won at the district court on preemption. It was appealed to the Eighth Circuit. It was argued by Ron Connolly, who was a partner at Powers. And the first question the judge asked, is there an express preemption clause in the 340B statute? There is not. Therefore, Congress did not intend to prohibit states from protecting certain areas or regulating certain areas outside of what the federal law governs. And so we won at the Eighth Circuit. Curiously, only a few days ago, you can see it in bold as the last kind of bullet here in purple, AstraZeneca filed a lawsuit realleging the preemption grounds under some interpretations of contract pharmacy replenishment models, claiming that title transfers and which has been the case since 1992, but somehow now all of a sudden contract pharmacies are diversion, despite over 30 years of practice. So anyways, they filed a lawsuit to re-challenge the law. We think it's spurious. We think the arguments are weak, and hopefully I get a chance to defend the law. Again, as a result of Arkansas's efforts, here are just a few of the manufacturers. I think we're up to 15 of the 32, 31 manufacturers that have restricted distribution of 340 drugs. You can review these after the presentation. I think the slides will be made available. But here are the manufacturers that have limited or changed or completely lifted their policies. This is huge. In Arkansas, this is millions of dollars in safety net savings to benefit underserved communities as a result of that state's kind of David and Goliath effort to protect its public health system. So this is in Arkansas, Louisiana. We're going to turn it over to Louisiana, which followed in Arkansas's footsteps and passed Act 358. So Arkansas's Act 1103, Louisiana passed Act 358. Now, here are the differences. Arkansas's law is enforced by the Arkansas Insurance Department. Louisiana's law is enforced by the Attorney General. So we have real prosecutors that are tasked with interpreting and enforcing the law against drug makers. That's a big deal, and it gives enforcement teeth. As another point, Louisiana's law regulates not only manufacturers, but wholesale distributors to prevent workarounds by drug makers working through intermediaries such as wholesalers to prevent distribution of drugs to contract pharmacies. And it uses the words directly and indirectly. I assisted with drafting this law, so I kind of know it. Directly or indirectly restricting distribution to contract pharmacies. It also prohibits interference with contract pharmacy arrangements. Now, one critical point is it contains a non-preemption provision, which permits a court to interpret the law in a manner that does not conflict with federal and state law. That's critical because that takes the wind out of pharma sales with its one argument that the 340B program is so comprehensive, it leaves no room for state regulation, and therefore it's preempted. Well, we have a clause here that permits a judge to read the statute in a way that is not preempted. And then also it contains significant enforcement teeth. The Attorney General has a lot of power under the Unfair Trade Practices Code, can even terminate a manufacturer's ability to do business within the state. And that's kind of what set the trend in drug companies starting to reverse their policies. Pharma sued, AstraZeneca sued, AbbVie sued. They're all going against the Louisiana Attorney General. Powers Law Firm is assisting the Louisiana Primary Care Association, intervened in all of those cases. Pharma added in additional claims, due process takings. They're basically saying that they have a constitutionally protectable right to their patents under patent law. Therefore, they can set their prices the way they want. And therefore, a law that regulates distribution of drugs is an unconstitutional taking without just compensation. Now, we all know that drug makers voluntarily participate in 340B in exchange for unlocking the massive markets of Medicare and Medicaid reimbursement. So they provide 340B discounts voluntarily to get access to Medicare and Medicaid reimbursement. So I don't think that's necessarily a constitutionally protected property interest. They allege that it interferes with their contracts, and they say it's unconstitutionally vague. Sorry about that. Briefing is concluded in Pharma and AstraZeneca's cases. We're still working through AbbVie's case. If you ask for my opinion, I think these claims are spurious. They're trying to forum shop to find judges that might fit their political persuasion. But at the end of the day, this is really a battle between multinational for-profit drug makers and the core of the country's public health system and the underserved communities throughout the country. So hopefully this all errs in favor of the 340B providers. So now I gave you a lot of background on the law, and I'll slow down watching my time. But let's get into how to fight, because I've been really involved across the country in drafting bills to protect 340B drug distribution, to protect against these manufacturers' spurious arguments, and also that contain adequate enforcement teeth to disincentivize the drug makers from continuing to violate the law notwithstanding. So you can see here just a couple of the states that have introduced the laws. I think we're up to 21 states now. I'm not going to read all these states off to you. I can tell you that of this list, so we have Louisiana and Arkansas have been passed. West Virginia and Virginia's laws have passed, but we're waiting on the governor to sign the bills into law. And there are a few other states that are moving pretty well. I think Nebraska is moving pretty well. And we're going to get into what the manufacturers are saying to slow this process down, and hopefully your blood doesn't boil too high when I get into it. And I've already talked about the drug makers that have revoked their restrictions, and the fact that many states are considering laws. But one critical point is that when you introduce these bills, make sure you seek counsel, because what you do not want to do, if you hear anything, hear this, you do not want to regulate 340B pricing or purchasing in your state law or bill. The 340B statute is a drug pricing and purchasing statute. Sets the price, says you may purchase drug at that price. But the statute does not state anything about delivery or pharmacies. And that's what the 8th Circuit ruled on. So just sit in your pocket, keep it easy, regulate delivery of drugs to pharmacies, and you should be fine. And so I just want to make sure you understand that, and please seek legal counsel to help with drafting the law. 340B legal counsel. Here's just a map. You can go to RDC340B.com, but here's our map of all the states, and these colors are pursuant to the voter persuasion of the state. You can see the 340B is a bipartisan issue because it really goes to the core of the nation's public health system. All right, advocacy. Now, this is where your blood boils. I already said, all right, so this is how you get a law enacted. And this is what I strongly encourage. And I want to see 50 states this next year with these bills. So regulate distribution only and have reasoned enforcement. And, we were looking at defining a package as a violation. Each package subject to the law would be a separate violation, and setting the penalties up to $50,000 per package. I know that's a little aggressive. So when I say reasoned enforcement, you want to look at the right agency. The board, the pharmacy are the ones that permit and license manufacturers. You can have dual layers of enforcement through the Attorney General and the Board of Pharmacy. I've seen one state do Board of Pharmacy, Insurance Department, and the Attorney General. And you want to keep it reasonable. We've cut that down in some states, 10,000, 5,000 per violation. But you want to get an advocacy coalition together. That's critical. You want to convene the stakeholders that will be able to really give that safety net message that the contract pharmacy bill is designed to protect. So we've primarily been working with the primary care associations who have led the effort and have been knocking on the doors of the state legislators. Ryan White clinics that are curbing the spread of HIV throughout the nation. Hospitals, the critical hospitals. And one thing I'll tell you a little note on that is the rural hospitals in your state have a strong message because they rely on 340B savings that are derived through contract pharmacies to keep their doors open. And if you don't have these hospitals and health centers, our nation is subject to calamity. If they close, then they don't have, in 30 miles, they don't have patients, underserved patients, don't have anywhere to receive services, not just discounted drugs or healthcare, food, travel, education, housing. All these services will be stripped right out of the underserved communities and will be retained as profit for multinational drug makers. So your rural hospitals have strong messaging. And then pharmacist associations. I've testified shoulder to shoulder with independent pharmacists, pharmacy owners that are contracted with safety net providers serving homeless people who are providing these critical services to these people for a reasonable dispensing fee. That pharmacist is pretty compelling to the legislators because pharmacists are one of the most trusted professions. That's what I think the Dream Team Coalition would look like. I've also seen the NAACP testify and other patient and advocacy groups testify. But the key is you have to speak directly to your legislators constantly. It's something like, I'm not a lobbyist, I'm a lawyer and a pharmacist, but this is what I've learned throughout this process. I just want to share what I know with you because I think the legislature, the General Assemblies will vote these laws and these bills into law, but you have to come with the right advocacy strategy. You have to combat pharma's misinformation. So the drug maker's primary tool is to mislead. And they don't just do it during testimony. Actually, what I've seen is they do it behind the scenes. And I'm not going to say the name of the company, but they're knocking doors and they're basically making up lies. And they're taking stats and flipping them and twisting them to make it look like safety net providers are the big bad wolf, not the multinational drug company that's disproportionately price gouging in the United States 300% higher than any other developed country, right, on their drug prices. So some of the misleading information that they say, all right, so firstly, before we get into that, you have to combat the constant misinformation by knocking on doors constantly, right? And identifying the champions of the bill, the sponsors, and allowing them to feed you the information about the misinformation the drug companies are using to kill the bill. So oftentimes, like right before a bill's about to pass, they wait to critical votes. Right before something's going to pass, one of the champions of the bill will let one of the PCAs or stakeholders know, hey, the drug industry is saying illegal immigration, 340B is supporting illegal immigration. Or 340B is expanding out of control, but they won't mention it's due to the rising cost of drugs, right? And so having those key champions for the bill, feeding you this information at critical moments will allow you to send broad messaging and know exactly what the pressure points are for the legislators who may be on the fence or the legislators who plan to kill the bill, so that you can actually directly contact them and provide the actual truth, right? The whole point, the whole game is providing the truth. And so I'm going to, and if you can bring experts to testify, that's very helpful. Like, for example, when I testified in one state, the legislator asked me, Mark, I'm hearing that, only so many pharmacies are located in underserved areas, right? But we all know, safety net providers, that we want a broad reach of pharmacies to reach all the patients. And I clarified that it's not just underserved patients that are a source of 340B savings. Congress intended for private insurance to reimbursement on private insurance to help support and fortify the nation's safety net providers so that they remain open. So having experts to kind of clarify what the actual purpose of the program is and how it works, a quid pro quo, drug makers participate in exchange for coverage under Medicare and Medicaid is critical. So I just I'm not going to go through all of these, but I just wanted to give you some information, what to expect, and then you can rebut it. You can create talking points. And, in one state that hasn't introduced a bill yet, I'm not going to say the state, but they're already going to, and I'm helping go to each legislator before, get their ducks in a row so that, they have yeses instead of nos when the bill is introduced. And they're anticipating the drug makers' misinformation and giving the rebuttal talking points before the drug makers even get an opportunity to say it. So they say hospitals allegedly abused the 340B program. So the hospitals are not providing transparency. I have the retort here. You can review this when you have time. There's a lot of rebuttals to that. 340B has expanded out of control. I've explained that there hasn't really been a significant increase in the number of covered entities. What there has been is a significant increase in drug prices, especially newly launched specialty drugs. And drug makers often cite, now in one state, the pharma testified is it's going to be $100 billion total purchasing, second only to Medicare Part D drug purchases. But they're not explaining that total purchase amount, dollar amount, is directly correlated to the cost of the drug. So you got the fox not only seeking to guard the hen house by restricting contract pharmacy arrangements, you also have the fox blaming the hen house for the hens that the fox slaughtered. So they're blaming the covered entities for their own rising drug prices. So 340B is expanded out of control. That's how you rebut it. Contract pharmacies are located out of state. We know that we want pharmacies where patients can actually get the drugs. We know that PBM limited distribution plans, especially manufacturers limited distribution specialty drug requirements, are why you would most typically contract with out-of-state pharmacy. So it's not the covered entity's fault. But they're going to use that as misinformation. Hopefully your blood's not boiling too much. 340B discounted drugs are not given to all patients, and we know Congress did not intend 340B to be strictly a 340 drug discount program. Studies show that full wraparound safety net services yield better healthcare outcomes. Congress intended private insurance. Again, rich people, well-off people with insurance are entitled to go to safety net providers, guys. And when their drugs are reimbursed, the covered entity uses those savings to support the full panoply of services throughout our nation's communities. That's how the program was. So combat that talking point that way. 340B should be exclusively federal. We all know matters of contracting, drug distribution, pharmacy law cannot be exclusively federal. Federal law is not going to dictate every element of a contract. That would be a red herring to get the program to fail. So I'm going to quickly brush over some of the federal reforms to the program. So what I would hope is a federal solution that addresses contract pharmacies, does not restrict the program and weaken the nation's public health system, but also would function as a complementary form of drug pricing regulation with state laws. Like we know we have payer anti-discrimination laws, we call it anti-pickpocketing laws, and we also discuss the distribution laws like in Arkansas, Louisiana. So we would hope that federal and state law could work together. So the Senate Gang of Six discussion draft, it adds contract pharmacy protections. It specifically requires a manufacturer to deliver drugs to contract pharmacies. That's important because we need to talk about how that would interact with the state law. It requests further information on patient definition, So if you have an opportunity to opine, we kind of take the position that more codifying the 1996 patient definition with some increased clarity on records and duration post initial service would be helpful, and it would not disrupt existing program operations. Child sites are to be clarified for hospitals by codifying the provider-based rules, but there's also additional transparency and reporting that can be considered a bit onerous, but we largely support the Angus 6 discussion draft. And you can read through it requiring an annual addendum to the Medicare cost report, requesting certain data about the number of drugs dispensed, the total safety net savings obtained through the program, and how those savings are reinvested in patient demographics. And it proposes to broaden HRSA's regulatory authority and audit authority to increase auditing on contract pharmacies, covered entities, child sites, and manufacturers. It provides a clearinghouse. One thing I'll say about the clearinghouse is that it's a mechanism of determining whether duplicate discounts have occurred, and then it shifts the liability of the covered entity to pay duplicate discounts under Medicaid managed care. Currently, many 340B experts believe that it's the state's responsibility to pay those duplicate discounts because the state's required for identifying Medicaid managed care duplicate discounts. But the point of a clearinghouse traditionally, I believe, was to prevent the duplicate discount from occurring in the first place. So that's one thing we're going to comment on is if covered entities are required to submit claims data, it should be before the rebate has been paid by the state in order to identify the duplicate discount instead of using it as a form of penalty. The information is submitted to the manufacturer, and it proposes commercial rebate protections, which I think is a problem. There's anti-payer discrimination language, new funding to HHS. There's a proposed user fee that only covered entities would pay of 0.1% of the savings. I think it should be manufacturers and payers paying that user fee because they benefit through the commercial rebates that propose to be protected. And it codifies a version of the legislative intent of the 340B program, which is to stretch scarce federal resources as far as possible, provide more comprehensive services to more eligible patients. Additionally, it protects contract. We talked about that. So now we're in Matsui. I'm sorry. So Matsui is a House champion, historical champion of the 340B program. Matsui protects contract pharmacies not by requiring delivery by manufacturers. Matsui protects contract pharmacies by prohibiting drug companies from conditioning 340B prices on the delivery location of the drug. That actually, I believe, could work in complementarily with state laws that require delivery because it's focused on the offer condition on delivery rather than requiring the delivery itself. That's an important distinction. Prohibits manufacturing conditioning the offers. Manufacturers that fail to comply are subject to excessive civil monetary penalties, which is a good thing. Codifies Congress's original intent. And I've already explained that she's been a proponent of the program. We're still waiting to see if there'll be others like ASAP 340B or some other legislative solution that would change the program. But if I was going to leave you with anything, I'd say federal reform during an election year, something passing, very unlikely. And I think it's really unlikely over the years hereafter. So your state law efforts and all the things I talked about forming a strong advocacy coalition, having experts that can really analyze the law and litigating the cases is critical and will provide immediate support because we're already up to 15 of 30 manufacturers that have lifted their restrictions in Arkansas. And that is all I have.
Wow, Mark, thank you for that, all of that information. It's super valuable, very timely. For me, the biggest takeaway for me on there, Mark, is the advocacy piece, especially at the state level. So appreciate the recap on the federal bills, but the advocacy piece hits close to home for all of us, hopefully. So thank you for that, Mark. Appreciate it. We'll wrap up. Anybody that has questions for Mark, please pop them in the Q&A button up top, and we'll address those at the end. With that, I'm going to turn the floor over to Nate Ulrich. Nate is our principal consultant that came on board in December of 2023. Nate, I won't read your bio. I'll let you introduce yourself to our clients here. So the floor is yours, Nate. Go ahead.
Great. Thank you. Let me just put my slides on the screen. All right. Everybody see that all right?
Yes. Yep.
Great. All right. Mark's a tough act to follow. It's pretty unusual to get to learn about an issue of state law from someone who participated in actually drafting the law. So that's a treat. Definitely echo his encouragement to get involved in advocacy. Appreciate that everyone has given us a little bit of their time today. I'm excited for the opportunity to introduce all of you to our consulting service. A little bit about me. I have about 20 years or over 20 years. You can see the gray hair, but luckily you can't see the top of my head, of experience in pharmacy and 340B with responsibility for pharmacy operations and 340B program management for most of that time, including as the health system executive leader for those areas. Our consulting service is intended to help clients, all clients, not just those who are our third-party administration clients, answer some key questions they have about their 340B program and about their pharmacy services to the extent they have them. I'll go through some of these. I want to make sure that we don't go over time here, but people say, are we getting as much as we're supposed to be getting out of our 340B program? Are we missing opportunities? Some of the choices we've made and the configuration elements in our program limiting the benefit that we could get? And can we take advantage in a compliant way of things that have changed in the 340B program since the last time we reviewed the laws, since the last time we updated our policies and procedures? And then on the pharmacy services end, should we open a pharmacy or buy one? If we have a pharmacy, do we think that it's performing as well as it ought to be? Are there things that we could do to improve the performance of that pharmacy, new services or strategies that we could undertake? We tailor our projects to the specific needs of each individual client, so they vary a little bit, but I'll describe two common types of projects that address many of the questions that people have been asking us. The first is this 340B program assessment. This is a performance assessment focused on finances. It's not a compliance audit, so we don't do a mock HRSA process. What we're looking at are things like your overall capture rate, looking for opportunities to expand your contract network, looking for issues within your third-party administration that might be blocking orders from pulling through. We look for lost opportunities that are caused by a number of different factors, and I'll go through what some of those are. Configuration settings that are filtering out eligible transactions, locations that aren't properly mapped. Issues with provider files are really common. It can have a really significant impact on the opportunity that you're capturing. Challenges with electronic prescription orders. If you have not implemented the capture of electronic prescriptions, that could sometimes significantly impact the performance of your program. Exclusions around drugs, especially in the area of manufacturer restrictions. If those aren't applied properly, it can have a significant impact. Outdated policies and procedures. If you've listened to some of the presentations from Mark, his other colleagues and folks in 340B, you know that the Genesis ruling in particular has evolved our perspectives around the definition of a patient. So there may be some opportunity in your policies and procedures to take advantage of that. If you're not capturing clinic administered drugs or other drugs that are in what we call the mixed use settings, or if you're not fully taking advantage of the opportunities around referral relationships. We also look at things beyond capture rates. We look at your training programs, what you do around performance management. We look at finance, operating procedures, staffing, leadership capacity, and then any other topics related to 340B that are appropriate for each specific client. The next project type is the pharmacy strategy and performance assessment. And that's for covered entities who either have or are considering an investment in pharmacy services. We look at the current areas of the services that they're offered, whether they operate pharmacies, what types of pharmacies they are, to come to an assessment of what the appropriate scope and sale of services is for the specific client in the context that they're in. We identify gaps in performance, management problems, cost structures, contracts that are not up to date or not competitive, staffing and leadership models that may need to be revised in order to improve performance, organizational support, technology, tools, vendor relationships, and more. During the project, we'll provide projections for what it would mean if your pharmacy services were to expand in more areas. Some examples of that type of expansion could be opening pharmacies, but it could also be adding infusion chairs, expanding clinical programs, and other things. And we'll make strategic recommendations on how to get to what the peak performance of your pharmacy services can be. Among those will be tactical recommendations to say, maybe you need marketing, maybe you need patient-facing tools, maybe you need specific additional services, maybe you need internal communications to providers, the staff, et cetera. It's possible that it may require some organizational structure changes, some additional contracts. We will cover the full gamut of what it takes to achieve at the highest level for the pharmacy strategy that makes sense for your organization. I talked about this performance management idea in both of those projects, and I wanted to just drill into what that means a little bit. It comes up in each project, and it's a really critical element of maintaining a high level of success, both in your 340B program and in any pharmacy services that you offer. So what's performance management? It's a persistent, and by that I mean, once you start doing it, you don't ever really stop, process of using data to measure performance, identify your opportunities, improve your efficiency, and reach your specific performance goals. So the first thing, it's important to set goals. We all develop budgets every year, but what I mean by goals are, if you think about where you are and what you're performing and what you're offering today, develop some concrete ideas of what you want to get to, what you think is possible. You might even set goals that you think might be impossible, but set clear, defined, measurable goals. And then pick measurements. There's an old adage of what you don't measure, you can't manage. So you need to be managing specific indicators of your performance that you can understand whether the strategies that you're trying to implement are effective. Those strategies need to be kept up to date. You need to be thinking about, what are we trying to do? Where are we trying to go, and how do we get there? So having a strategic plan that covers your pharmacy service and your 340 program can be very important. And then implementing those strategic plans is key. Having a plan that you don't follow is not very effective. Capacity assessment. In order to run a pharmacy or to run a 340B program, we need people, we need resources. If we don't have those resources, then it can be difficult, if not impossible, to execute on a strategy that brings us where we want to go. So part of a strategy assessment or performance management assessment is to say, given our goals, do we have the capacity that we need to get there? Do we need to add people? Do we need to add vendors? Do we need to add tools, technology, software, et cetera? And then routine performance processes. So that's looking at opportunities, looking at missed opportunities, leakage, as we call them, or gaps in our processes. And then collaborative accountability and oversight. Let me just explain what I mean by that. As pharmacy leaders, we typically are solely responsible for how well our programs perform. And sometimes we report out to others about that performance. But those silos can be challenging, and it can be very effective to break some of those down and bring in people from different departments, including our levels of leadership above us, to say, let's all talk about what we're trying to achieve, get on the same page, get support from our whole organizations on what we're trying to achieve, and then perform collaboratively that oversight role to say, is this working? Do we need to pivot? Are there resources that we're missing that we need, et cetera? I mentioned measurements and key performance indicators, these KPIs. So I wanted to just describe what a few of those might be. Total capture rate. So that's all the orders your organization sends out, and how many of those orders actually go to either your own pharmacy or the pharmacies that you're contracted with. I like to see greater than 80% for those. If you don't know what your number is, or if you have a number that's lower than that, then it's likely that there's an opportunity for you to expand your total capture rate. Also important, especially in an era of manufacturer restricted items, is this internal capture rate. So that's the percentage of all your orders that go to an in-house pharmacy. We've seen numbers for that range from 4 or 5% up to 45, 50% or higher. In general, between 20 and 30% is a reasonably well-functioning program that still leaves some opportunity for growth. Contracted pull-through, I mentioned that before. You may send your own prescriptions that you issue to people who are clearly your patients to your TPA, but choices you make in the TPA, the access to the data that they may have or may not have, can result in some of those orders not being qualified. So we want to see at least 80% eligibility for those orders that are sent to your contracted pharmacies that are filled. And I put that filled in italics because, as we all know, many of the prescriptions that are issued by doctors and other providers are never actually filled. We look at capture rates in specific areas, and I think this is a useful KPI, even if you have your high-level capture rate numbers. Those special areas can be specialty products, specialty light products, which are those specialty or high-cost drugs that can be dispensed by any retail pharmacy, products intended to treat HIV or diabetes, like long-acting insulins and GLP-1s. Those aren't specialty products. They're not limited in any way, but they do tend to be high volume and a high cost, and it's worth understanding what your capture rate is in those areas so that you can develop specific strategies around increasing that rate. Assistance program enrollment. Assistance programs are a great way to draw people in to your in-house pharmacies. It takes advantage of some of the things that make community organizations that are participating in 340B what they are. We have access to patients that need help. We are situated in a way that we can help them with the needs that they have, and we can use that assistance to bring them into our own pharmacies where both they and our entities will benefit. And then finally, in the mixed use area, there's several different types of things to measure for clinic or hospital administered drugs, leakage, the proportion of WAC purchases, and that sort of thing. So it's important to have KPIs. I only included a few here. There are other that you could potentially choose. I wouldn't suggest anyone have a long list of performance measures. Really, you need a handful, 3, 5, maybe sometimes more, depending on what you're trying to achieve, because you are going to focus a lot of energy over time in improving those specific rates. And the more of those measurements you're trying to follow, the harder it can be and the more fragmented your attention will end up being. So let's see, where am I in time? I think I'm doing pretty well on time. And so that is actually my last slide. I wanted to give people my contact information. That's my email address. That's my phone number. Feel free to reach out. Look forward to the opportunity to speak to some of you or many of you directly. Thank you very much.
Great. Thanks, Nate. Appreciate that. Everyone that's trying to write down Nate's information, we are going to share this this recording probably early next week. So if you did miss that, it'll be in there, and obviously you can reach out to any of your client reps or implementation or Alex or Jillian as well. We'll have Nate's information to share. So I think with that, Nate, thank you. That was great, useful. Mark, again, appreciate all of your insight there. And I think we do have some questions that we can go through. Rachel has been monitoring those. Rachel, do you have those available? We can walk through those.
Sure. The first one is for Mark. So the bill in New York doesn't seem to be moving since it was introduced last year. This person's been attempting to contact the bill sponsor, but hasn't been getting a response. Do you have any expectation the bill will move forward soon?
I am not the attorneys working with New York. I think that, even for the bills that are expected to move, there's significant pushback. And so, one thing I'll say is what I've seen is anything can happen. So, I think that if the bill sponsor is not reaching out, keep contacting them, knock on their door, learn exactly why the bill's not moving. I am not opining on New York's bill, but I think that, talking with the bill sponsor will help understand what may or may not be causing the bill not to move. It's very likely that drug makers are spreading the misinformation that, we've rebutted in this presentation, and we have talking points that we've written for clients. But, first you got to learn, like we discussed, what is causing it not to move. So if you're not hearing any movement, I think it's unlikely, but you can change that, and you have to change that. Like, don't feel like you can't do it. I've seen bills that are about to die right at the vote, and we made one call to the person who's going to kill it, and then the bill passed. So you just got to keep reaching out, and just go down to the Capitol or wherever the General Assembly meets and knock on the door.
Thank you.
Awesome. Thanks, Mark. Rachel, before we move on, I just want to give the group, from our perspective of that particular bill in New York, for the person that asked this question, was introduced in 2023. Haven't seen any movement, as this person noted. And the bill number, for those of you who are involved with any advocacy efforts, was introduced in the Assembly in New York, and it's A7789. So that's just for everyone's general knowledge. I think we can move on to any more questions, Rach.
Perfect. The next one's for Nate. You mentioned something about infusions. How would that impact my FQHC, and am I eligible for this service?
Sure. Great question. Thanks. And I'll add to Mark's question that if you aren't involved, but you'd like to be and you don't know how to get involved, every state has a primary care association and a hospital association, and it's a great place to start. They'd love to hear from you, love to support your efforts. So reach out to those folks. So infusions. hospitals have been taking advantage of infusions for a long time. For many hospitals, a huge proportion of their benefit for the 340B program comes from outpatient infusions, but they're facing some challenges. Many don't have access to orphan drug discounts because they're subject to the orphan drug exclusion. Many, if not all of them, are fighting with payers over hospital-based infusion costs because it's a very high-cost place to offer infusion. And they have very, very strict rules, pharmacy rules in general, around the preparation of sterile products. So a lot of those challenges don't apply to grantees, including FQHCs. Additionally, many of our grantee friends and clients are located in areas where patients have a need for better access to infusion services. So those things together create a pretty significant opportunity for grantees to look into the viability of infusion services for their entity. There are some questions that people in each state would really like to answer. You know, there's some scope of grant questions, there's some Medicaid and Medicare reimbursement questions that you would want to verify, but it's absolutely worth anyone looking into those things as an area of pharmacy services that they may want to branch into, even if they won't do something like open a pharmacy.
Thank you. This next question is for Mark. If a state law is already passed and then a federal bill gets passed in both houses, which one would we have to follow?
Yeah, so that goes to the preemption question. That's what I mentioned with respect to the difference between Matsui bill and the Gang of Six discussion draft. The law is that unless the federal law contains an express preemption clause, there's two ways you look at it. One, states can pass laws that govern conduct that the federal law does not govern. Or two, states can set higher standards for regulated entities than what the federal law governs. So if we're talking about delivery of drugs under, in the two cases of Hillsborough and Flora lime and avocado growers, Supreme Court cases that basically say, in the interest of public health and safety, a state can set a more restrictive standard on a regulated entity than the federal law. So drug makers must deliver drugs. Drug makers must deliver drugs this way and will be subject to these penalties at the state level. The Eighth Circuit didn't really get into the higher standard argument and just went with the first regulate conduct that's not regulated at the federal level. So both Matsui and Gang of Six tend to seek to govern PBM, discriminatory practice. Well, no, Matsui does not govern PBMs. Gang of Six governs PBMs. Both govern contract pharmacies, but the way that Matsui governs contract pharmacies will still permit state laws that require delivery, because Matsui only says don't condition the offer of 340B prices, rather than manufacturers, you must deliver. So I think Matsui's is probably going to allow both state and federal contract pharmacy protective laws to remain. I think that unless the Gang of Six contains what we call a savings clause, basically stating this is what states may regulate and how, I think we're going to have an issue with both the PBM laws, and it's like 33 states have passed anti-pickpocketing, anti-discriminatory reimbursement laws, and our Arkansas, Louisiana, possibly West Virginia, and other states that are passing the contract pharmacy laws. So I just gave a whole course on preemption right there.
Thank you. Nate, what are the major considerations of deciding to open an in-house pharmacy, and who should be involved from my FQHC when trying to make that decision?
Great question. Opening a pharmacy is sort of like any other potential new business venture in that you want to understand your risks and your opportunity. It goes into that, some of the things I mentioned, like understanding what your current capture rate is, what you're losing right now due to manufacturer restrictions, how much you would need to invest to open a pharmacy, and what you can expect if you have a pharmacy or you don't have a pharmacy, what you can expect in terms of improvement overall in your financial results. Those are all key financial considerations to whether it makes sense in any context to open a pharmacy. I think it's also worth asking certain questions like, am I going to run it myself? Do I work with someone else to help operate the pharmacy? Are there people that can help me invest in what it would take to open one? And then beyond that, I think it's important to consider other pharmacy services that aren't opening a pharmacy. I mentioned those clinical services. Those can offer really seriously needed help to patients. There are lots of patients out there who could benefit from new drug therapies that aren't getting them. Additionally, nowadays, the interaction between patients and pharmacists in those clinical contexts can give rise to 340B eligibility on its own. And there are other things like the infusion services I mentioned, et cetera, to think about when you say, should we offer pharmacy services? As far as who should be involved, it's a big question in any organization that involves people in legal, compliance related to 340B program, executive leadership, pharmacy leaders, if you have those, any 340B program specific staff you may have. So you want to make sure you get buy-in from everyone, and that includes the provider staff. If you have physician leadership, nursing leadership, getting as many people involved in that process and as strong a consensus as possible is really critical to having a successful venture. But in general, I'm a huge advocate of covered entities controlling their own destiny with pharmacy. With all the uncertainty around manufacturer restrictions and the future of contract pharmacy, there are really few things that you can do to take some control over the situation, and offering your own pharmacy services at some scope or scale is a really key way to do that.
Okay, thank you. We just have one last question. So Mark, you mentioned the clearinghouse. What realistically would that look like for anybody who's participating as a covered entity? And what would they have to provide for a clearinghouse?
So there's what the law proposes, the Ganga 6 bill would propose is mirrored on PROTECT Act to some degree, which is a PBM bill, right? West Virginia, I think she's no longer seeking re-election. But so what it proposes is that the covered entity, not the pharmacy, will be responsible for submitting claims data. For hospitals, it could be either point of sale, meaning, requiring your pharmacies, contracted pharmacies, in-house pharmacies, to put claim identifiers and to submit claims data to the clearinghouse. We don't know, how that would look specifically, but for grantees, it proposes to allow retrospective batch claim submission, which is obviously more workable, less burdensome, to submit it, quarterly or whatever, to the clearinghouse. Obviously, we would propose both covered entity groups to submit the data retrospectively, and we'd obviously propose that the data be limited only to Medicaid and Medicare Part D in 2026 when the IRA becomes effective, but for the purpose of preventing the duplicate discounts from occurring before. But basically, you have a data field set, like a report where you have to fill in claims level data for various types of information, like, was it 340B, RX number, whatever it is, to identify each claim. And then you submit it to this neutral clearinghouse. It's mirrored on it's supposed to be mirrored on the Oregon model. And so I think the government proposes to find a vendor to provide the service, like a national, like a vendor to provide the clearinghouse service. And it's going to be electronic data submission with respect to what, and there's going to be vendors out there that are going to help you facilitate that. I don't know if that's something that Hudson plans to do. But there's going to be vendors out there to help you collect, software vendors to help you collect the requisite claims data for the requisite fields, data service, pharmacists out there, data service, if there's any kind of, any other identification information that goes on it, and submit it. The key is we would like it to all be retrospective, to be convenient to the safety net provider that's already cash strapped, providing services that are uncompensated or undercompensated. But it seems like the drug makers are in the ear, and they're trying to get it to be more onerous on hospitals, which is gonna, compromise, in my opinion, services throughout the country. So submit comments. They're due April 1st.
Perfect. Thank you so
That's
much.
great. Yeah. Was that the last question, Rachel?
That was the last
Was it?
question. Yep.
Okay, great.
Mhm.
Thank you, Mark, for that. Just a comment on Mark's statement there. We will at Hudson 340B be prepared to aggregate that data for the clearinghouse when the time comes. We got a little bit of runway in front of us, but we'll certainly be prepared and ready to roll. So with that being the last question, we're approaching the 2:00 hour here. So Mark, thank you very much for attending. Nate, thank you. Rachel, thank you as well. And to the clients, a special thank you for attending and spending a little bit of your Tuesday afternoon with us here. So we will catch up with you all soon. Appreciate the time, everyone.
Thanks all.
Thank you.
Bye-bye.